Okay, let's begin this whole thing by looking at the diagnostic and therapeutic procedures that we do for our cardiovascular patients. These procedures evaluate the function of the heart by monitoring for enzymes, using ultrasound to visualize the heart. We can determine how the heart responds to exercise. We use catheters to check blood volume, perfusion, fluid status, how the heart's pumping, and to the degree of artery blockage. We need to be familiar with these procedures because we need to explain them to our patients. We need to interpret the findings for our care that we're going to provide these people. So to begin with, we're going to look at basic enzyme and lipid profile. Cardiac enzymes are released into the bloodstream when the heart muscle is ischemic. So the muscle itself isn't getting enough oxygen. It becomes ischemic. It releases these cardiac enzymes. The lipid profile looks at cholesterol levels, and it's used for early detection of heart disease. The enzymes are actual specific markers for an MI, for an ischemic event, so we know something has happened. And what indicates that we need to draw these blood samples? Well, it would be angina, someone comes in with a chest pain, signs and symptoms of MI, known heart disease and comes in with some other signs and symptoms, and hyperlipidemia. So when we draw these blood tests, and they're simple, they're typically fasting, we're going to explain the reason to the patient, and it's drawn very easily by a venipuncture. And we're looking at the enzymes. The CKMB, which is the creatine kinase isoenzyme, and it's most sensitive to the myocardium. So it really should be 0% of the total CK, but the reference range is 30 to 170. This elevates within 4 to 6 hours of the myocardial injury and will stay elevated for 3 days only. So it's a very short little window that the CKMB elevates and stays elevated. On the other hand, the troponin T should be less than 2 nanograms per liter. It elevates in 3 to 5 hours, but will stay elevated up to 3 weeks, usually between 2 to 3 weeks. The troponin I, less than 0.03 nanograms per liter, elevates within 3 hours as well. Now, these all come up right away during the myocardial injury, but the troponin I stays elevated only for 1 week or to 10 days. So they all shoot up right away, and then some stay elevated longer. The myoglobin should be less than 90 micrograms per liter, and it elevates within 2 hours of ischemic event, and only stays up for 24. So using these parameters and how long the elevation happens, they can get an idea of how fresh the MI is. Now, when we're looking at cholesterol, total cholesterol should be less than 200 milligrams per deciliter, and that's a screening used for heart disease. It indicates an increased risk for coronary artery disease if it's elevated. In your textbook, it says it's greater if the older adult over 70, it's 144 to 280, and then with the average adult, it's 122 to 200 in Iggy's book. A good reference range, though, is to know that it should be less than 200. Plasma high-density lipoproteins, HDLs, I call them the happy cholesterols. We like them. They have, for men, should be between 35 and 65, and for women between 35 and 80 milligrams per deciliter. And that's a good thing. The HDL and LDL ratio should be 3 to 1. And those ratios protect against coronary artery disease. The LDL, being the lousy cholesterol, should be less than 130. And in your textbook it says less than 180. So that's real specific. Anyways, you want it low. It can actually, that LDL can actually make up to 70% of the total cholesterol, so we want that to be low. And then triglycerides themselves, those are should be less than 150, and they can actually evaluate for atherosclerosis. Okay, I want to talk about echocardiograms. This is just ultrasound of the heart. It's used to diagnose valve disorders, so we're looking to see if there's any regurgitation or stenosis between the chambers. It also looks at size of the heart, so we can see if there's any cardiomyopathy. So we're actually looking at the actual structure of the heart with an echocardiogram. Patients with cardiomyopathies and heart failures will be candidates for an echocardiogram, and maybe somebody who hasn't had an angina, myocardial infarction, they may actually go in and do an echo. It's a very non-invasive procedure. And we just want to tell our patients that what the reason for the test is, that it's pain-free. They may have to lay on their left side and remain still for up to an hour. There's no nursing actions that happen during the procedure. And then afterwards, we just need to reassure the patients that the procedure was done and that they can rest comfortably following, and their physician will follow up with them. A stress test, this is where the cardiac muscle is actually stressed through exercise by a patient walking on a treadmill. It gives us information about workload of the heart, and once the patient's heart rate reaches a certain rate, the test is discontinued, or they stop the test if the patient starts to have cardiac symptoms. If on the EKG machine they start to see ST segment elevation or depression, they're going to stop, because that's going to give us an indication of cardiac ischemia. So a patient who goes for a stress test with somebody maybe who has angina, not during the angina of course, but history of heart failure, MI, dysrhythmias, these patients typically are sent off to have a stress test. You need to get an informed consent from your patient and explain that they're going to be walking on a treadmill, so they need to be wearing comfortable shoes and clothing. Now, if they're in the hospital, often we just put on the little socks that have the treads on the bottom, but if somebody can bring them in some running shoes from home or athletic shoes, that's the best thing for them to be wearing on that treadmill. And if they're disabled enough that it could be physically challenging for them, and they may order a pharmacological stress test, which is typically done with adenosine, or adenocard is another name for it, and that's given to stress the heart instead of walking on the treadmill, and then they're sent off to nuclear medicine for scans that way. So usually we have our patients fasting for 2 to 4 hours. We just don't want them to have a lot on their stomach when they're going to be exercising, and that's just all according to agency policy. We don't want them to smoke tobacco, alcohol, not drink alcohol or caffeine. We don't want any stimulants on board prior to the test. If you happen to be one of the nurses that are in the suite when they're doing this, you may be monitoring vital signs, but there's a protocol that they all go through. It happens to be called the Bruce protocol. I don't know, I guess Bruce thought of it. And it depends on the elevation and slope that's keyed into the treadmill and how fast they go on it, and there's parameters for all that. So once that's over, you're going to monitor the client again and watch his blood pressure and check it frequently until he's stable, and then the provider will give them feedback of the findings of the stress test. I wanted to mention one thing about on the last slide, and I can't go back to it without ruining the recording, but other levels that they're going to look at is they're looking at homocysteine recently and C-reactive protein. So those are two other lab values that you want to be paying particular attention to, and you can review that in your textbook. Cardiac angiography, also known as a cardiac catheterization, it is an invasive diagnostic procedure, and that we do that to evaluate the presence and the degree of coronary artery blockage. Angiography can also be done on the lower extremities to determine blood flow for peripheral vascular disease, peripheral arterial disease, and it involves inserting a catheter into the femoral artery. Sometimes they use the brachial vessel, but typically it's into the femoral, and they thread it into the right or left side of the heart. The coronary artery narrowings or occlusions are identified by injecting a contrast media under fluoroscopy. So they inject a dye, look at it under a fluoroscopy camera, or fluoroscope, whatever, a camera, x-ray camera, and they're able to see the narrowings. Like you can see on this image on the top left, it actually identifies the left main, left anterior descending, circumflex, diagonal. So you can see the coronary arteries. There's no narrowing on this particular view. It just gives you a nice view of the coronary arteries themselves. So why do we do these cardiac cath? Well, it's typically for someone who has unstable angina, who has actually had EKG changes where they're actually seeing an ST segment elevation or a depression. Maybe they have a T wave inversion. So there's indications on the EKG to do an angiogram. It also looks, they know there's heart disease. They want to confirm the actual location and the extent of the disease, so they'll send them off to the cardiac cath lab. So what do we do? Pre-procedure, we have to get an informed consent. We have to make sure that the patient is NPO for 8 hours because they lie flat. We don't want them to risk aspirating on anything. Make sure that the family and client understands what's going on. Have them tell you what's happening and explain the procedure to you. We want to assess for iodine and shellfish allergy because their patient's getting contrast media. Now, being an old interventional radiology nurse, I know that this is non-ionic dye that they're using these days, which means it's non-ionic, means there's no iodine in it. However, there have been studies done that individuals who have a propensity to have an allergic reaction such to iodine, which means they have a shellfish allergy, something like that, they have an increased incidence of having allergic reaction, and it's not related to the iodine. But for testing purposes and for NCLEX, whenever anybody's getting any kind of dye, you want to check for shellfish or iodine allergies. Please do that. These patients need to be pre-medicated with Solumedrol and Benadryl, so they need an antihistamine and a corticosteroid to decrease that inflammatory response. So, very important to assess for an allergy. And we also want to assess their renal function because that dye is excreted through the kidneys. So we want to know what their BUN and creatinine is. Okay, I told you about the pre-meds. Now, client education. We want to tell them that they're going to be awake. They'll probably be sedated. They get what we call a conscious sedation. You might be the nurse in the procedure room providing that. Typically these days we're giving Versed and maybe they use Demerol, Versed, and something else has just gone out of my head, so I'm not going to talk about it. Anyways, conscious sedation. And a small incision is made into the groin where the physician inserts that catheter. The patient will feel a warm, flushed feeling when the dye is inserted. Some patients feel like they are urinating. It's sort of like this warm flush to the groin area. Tell them that's normal. They're not. They're not going to get wet. They just feel that warm sensation. And after the procedure, they must keep that affected leg straight, and they will have a pressure on it, perhaps a sandbag, although they're using those less and less. And they are using other devices, closure devices, to hurry up with the hemostasis to occur. Like I said, during the procedure, you might be giving sedation. You're going to be continually watching their vital signs and their rhythms. That is the role of the RN in the room, is to monitor the patient's vital signs and their cardiac response. And must be prepared to intervene if there is any kind of dysrhythmias, and you have your resuscitation equipment and medications ready within reach. So there's a crash cart in the room, and if you need to, you will help with resus. Post-angiography, be it cardiac or any other parts of the body, pretty much the same procedure. We're going to look at the vital signs every 15 minutes times 4, 30 times 2, and then every hour times 4, and then every 4 hours, or whatever the hospital protocol is. We're going to be watching that groin site at the same intervals as we're taking those vital signs. We want to really have a good look at that. We're going to be monitoring their distal pulses. We assess their pulses pre-procedure and post-procedure. We want to see if there's any changes. We're going to pay particular attention if all of a sudden one leg becomes a little bit cooler than the other, or we lose a pulse, because remember, we're on the arterial side. So if a clot does form or become an embolus, it's going to go towards the feet, right? Because it's on the arterial side, it's going to go downwards. It's not on the venous side, it's on the arterial side. So we would have a clot go down to the foot if something happened. So we would start getting a cold foot. So we're going to be documenting the pedal pulse, the color, the temperatures, that old circulation sensation and movement. The patient has to remain supine position with their extremity straight for a prescribed time. Sometimes we have a vascular close device that sometimes increases hemostasis following removal of the catheter that was in the groin. And if you watch the video that you were instructed to watch, you're going to have a better idea of how this whole procedure happens. Older adults have arthritis, and it can make them lying in bed for 4 to 6 hours very, very painful. So we may be giving some medications for these patients. Always have continuous cardiac monitoring. We're looking for dysrhythmias. If we did some stenting or some angioplasty, there can be reperfusion dysrhythmias. They are expected and they need to be treated. We will give antiplatelet or thrombolytic agents as prescribed to prevent clot formation and restenosis. That's as prescribed, because initially we don't want them to bleed because we have a groin site, remember? But once they're getting the thrombolytic agents post-procedurally, we could be giving them aspirin, clopidogrel, which is Plavix, ticlodipine, which is Ticlid. They may be getting heparin or Lovenox, which is low molecular weighted heparin. They might get integralin. They may get some analgesic, like I mentioned. They might need some anti-anxiety agents like Ativan. We want to have a close look at their I and O. Typically, we're going to run probably good fluid, a liter of fluid through them to hydrate them and to flush that dye out. Very carefully with patients who have a history of failure. We don't want to do any fluid overload. The contrast media itself acts as an osmotic diuretic, so we're going to have that diuresis occur. If we are removing the sheath from the vessel, you need to have special training in doing that and applying the pressure to that arterial site for a prescribed period of time. We don't see that happening as much anymore because we do have these different vessel closure devices. They're collagen products typically, and we still need to watch because they do fail at times. We're going to watch for that vasovagal response if we actually do have to apply pressure onto the groin, and that's when we see our patients go into a hypotensive mode. They become bradycardic, they diaphoretic, they may actually even lose consciousness, and that's because of the compression on the nerves. After the sheath's out, a pressure dressing is applied. So what do we tell our patients? Well, prior to when we're discharging them, we want them to avoid strenuous exercise for a period of time, and that's going to be individualized based on the physician. 4 to 6 days is a good time to talk about. Immediately report any bleeding from the insertion site. If they have any kind of chest pain, shortness of breath, any changes in color of their foot in their extremity, starts to feel cool. Got that bluish or color to it. If it has any numbness, we don't want them to lift anything for another prescribed period of time. A week is a good time to say, 4 to 6 days. A week is good. But it's going to differ from institution to institution. There's no hard, fast rule. If they had a stent placement, they might be on anticoagulation therapy for about 8 weeks. And we're going to talk to our patients about taking that anticoagulation therapy and how that they're going to have regular blood tests if they're on Coumadin, correct? Everybody remember that? To avoid activities that's going to cause bleeding if they're on an anticoagulant. So, soft toothbrush, wear your shoes when you're not in bed so you don't step on something, stub your toe, knock your shin on the dishwasher, etc. And we're going to encourage them to follow guidelines where they're going to manage their weight and have a low-fat, low-sodium diet, exercise, stop smoking, and no booze. So, lifestyle changes. Now, with anything, with angiography, there are complications that can occur, cardiac tamponade being one of them, and that can result from accumulation of fluid in the pericardial sac. And what happens, that fluid fills up and it pushes on the myocardium itself and restricts contraction. This is a very, very rare complication. But the signs and symptoms of cardiac tamponade include hypotension. You're going to see JVD. When you put your stethoscope on their chest, the heart tones will be very, very muffled because the fluid, you're listening through that fluid in the pericardial sac. They will have paradoxal pulse or pulsus paradoxus, and that's when there is 10 millimeters of mercury or more in their systolic blood pressure reading between inspiration and expiration. So you're taking their blood pressure and it vacillates 10 millimeters of mercury during inspiration and expiration. That's called pulsus paradoxus. So this is a cardiac emergency, and they do a pericardial centesis to relieve the pressure. So they actually put a needle right into that pericardial sac through the chest and take that fluid off. Really very rare. Don't get twigged out about it. But it's an emergency. You need to call the physician immediately if you're seeing these signs and symptoms. Start fluids because they're going to be hypotensive. Get an x-ray, get an echo, start the ball rolling, and then prepare for that pericardial centesis. Last one I did, I think we did at the bedside. So yes, it does happen, but not that often. Don't get excited. More often than not, we see a hematoma formation, and that's typically right at the groin insertion site. And that's because blood clots form near that insertion site, and we're going to look at that groin, keep an eye on it, hold pressure if the bleeding is uncontrolled, and we're going to monitor that peripheral circulation, and we're going to assess, like I said, for their distal pulses, but we'll also think about where else clots could take off from. If there was any clots in the heart, we're going to watch for signs and symptoms of stroke. That would be an emergency. And of course, we would notify the primary care provider. If we see restenosis of the treated vessel, that's another complication. So a patient who had a coronary artery angioplastied open, and then we have clot reformation in that coronary artery. It can occur immediately or several weeks after the procedure itself. We'll see pattern changes in the ECG, and they may have a reoccurrence of their chest pain. We want to make sure that the cardiologist is known about it right away, and typically the patient goes right back to the cardiac cath lab when that happens. Another and final complication is the retroperitoneal bleeding. And that's where it bleeds into the retroperitoneal space, which is the abdominal cavity behind the peritoneum. And that happens when they're trying to catheterize the femoral artery, but they go through and through. So it's a piercing of the artery itself, and perhaps then they readjust and they're able to get into the femoral artery, do the procedure. Then they take the sheath out. Perhaps the sheath was providing some kind of tamponade so that there would be no bleeding out of the artery. And then the sheath comes out, and then we have that retroperitoneal bleed. These patients will complain of flank pain, and you will see hypotension. This is another emergency. You need to notify the physician immediately. Get fluids going, blood products going. So they're bleeding internally into that peritoneal space, and they have to go in for repair. And I've seen this happen just once, but it was an emergency, and we had to move very quickly.